Now, in order for you to follow and understand the concept on the disease, you really have to know first, understand the normal cardiac cell electrophysiology para madali na lang maintindihan ang disease related to those rhythmic activities. Now, we have this condition called arrhythmia. Arrhythmia, this is generally defined as a heart condition where disturbances or disorders in pacemaker impulse formation or disorders in contraction impulse conduction or both results in rate or timing of contraction of heart muscle that is insufficient to maintain normal cardiac output. So what does it mean? In arrhythmia, there are problems in the following. Number one, may problema sa pacemaker impulse formation. Ibig sabihin, may problema or ang problema mismo ay ang pacemaker, ang sinoatrial node. Or kaya naman sa arrhythmia, pwede din ang problema ay ang parts ng cardiac muscle which is responsible for impulse conduction. So under dito, sa contraction impulse conduction, yung mga parts ng cardiac cell, papasok dito yung atrioventricular node, yung bundles, di ba? Or kaya naman yung Purkinje fibers. Okay? So generally, kapag nagkaroon ng alterations, disturbances, disorders in the conduction system ng heart, particularly sa sinoatrial node, and also in the parts of cardiac muscle where conduction of impulses occurs, that could lead to insufficient cardiac output. Now, ano ba yung pwedeng mangyari kapag insufficient ang cardiac output? Most probably, diba, that will result to decreased blood volume that will be distributed in the peripheral tissues. Diba, baba ngayon yung output ng heart, okay, blood volume that was ejected by the heart to be distributed to the peripheral tissues. Okay? So, insufficient yung cardiac output. Di enough, kumbaga, yung blood, okay, to meet the demands ng peripheral systems. Now, kung kulang yung blood supply in some parts of the body, that could result to complications. So, yan yung pwedeng problema. Okay, so again, factors that causes all this, okay, is due to problems sa mga parts involved in cardiac impulse conduction system or yung mga involved sa electrical system of the heart. Now, the following are the causes of arrhythmias. So, these are the causes of arrhythmias. Number one, kapag may history ang patient ng myocardial infarction, that could lead ultimately to arrhythmia. Okay, so yan yung isang causes, dahilan ng pagkakaroon ng arrhythmia. Also, pag may atherosclerosis ang patient. Okay, that's why if you have atherosclerotic plaque, okay, meaning pag may plaque, may deposition ng fats, for instance, sa arteries, that could also be a trigger of arrhythmia. And also abnormal sensitivities sa mga autonomic transmitters. For example, kapag may abnormal sensitivity sa acetylcholine and also sa norepinephrine. Diba? Acetylcholine, yan yung neurotransmitter ng cholinergic autonomic nervous system. Norepinephrine, yan naman yung sa sympathetic nervous system. Again, pag may abnormal conduction involving neurotransmitters acetylcholine or epinephrine, that could also cause arrhythmias. Diba, I had discussed sa part 1 na yung autonomic nervous system, para tsaka sympathetic nervous system, they have effects in the electrical conduction systems of the heart. Say for example, they could affect heart rate, yung chronotropy. They could also affect conduction velocity, yung dromotrophy. Not dromotrophy, dromotropy. Okay, dromotropy. So these neurotransmitters acetylcholine and norepinephrine, they are autonomic related. Kaya may effect sila. Okay? Possible cause din sila ng arrhythmia. Also, administration of general anesthetics. Okay? Administration of general anesthetics. Okay, that could also cause arrhythmias. Kasi in general, ang mga general anesthetics, please take note, they are considered ion channel blockers. Okay? General anesthetics, mga ion channel blockers sila. Okay? They are said to be ion channel blockers. And recall, na-mention ko rin sa part 1 ng lecture video na ang ion movement, yung ion movement that is very essential for normal conduction system. Okay? Therefore, kung general anesthetics, mga ion channel blocker sila, and then systemic yung administration, pwedeng makarating yung gamot sa heart. And so by reaching the heart, that drug may possibly alter ion movement in the heart. Okay? That is why also, later, kapag may abnormalities na sa movement ng ion channels, okay, or movement ng ions sa heart, okay, pag may abnormalities na doon, there are also drugs na yung mechanism of action is to alter, to block that particular ion channel. So later, pag-abot nato sa drug, naapod tayo mga anesthetics na may anti-arrhythmic activities din. Okay? And then in some cases, pwedeng unknown ang cause ng arrhythmia. Okay? So possible na hindi alam. Okay? Hindi natin alam ang pinagmulan ng condition. Okay? So moving on, let us now discuss the pathophysiology. Again, we will now discuss the pathophysiology of cardiac arrhythmias. Okay, so as presented in the slide earlier, di ba ang problema sa arrhythmia is that hindi tama ang pacemaker. Okay, hindi tama yung pacemaker, or kaya naman, hindi tama yung nagre-receive ng conduction. Okay, wherein yung involved dyan yung mga cardiac muscles aside from the SA node, or pwede din naman both yung problema. Okay, now this problem could result to either too fast or too slow conduction. Okay, too fast or too slow conduction. So, ibig sabihin, di ba, pag arrhythmia, that is defined as irregular, nagkakaroon ng irregular heartbeats yung patient. Hindi ibig sabihin na pag irregular heartbeat sa arrhythmia, sobrang bilis ng tibok ng puso. Pwede din na sobrang slow yung rate ng heartbeat, okay, causing bradycardia, or sobrang bilis ng rate ng heartbeats, okay? So that causes tachycardia. Okay? So again yung problema sa impulse formation, problema sa impulse conduction, or both, that could result to too fast or too slow conduction in the heart. Okay, tandaan, kapag too slow ang conduction, apparently, that results to bradycardia. However, dili ta mag-focus sa bradycardic effect ng arrhythmia. Okay, dili ta mag-focus sa bradycardic effect ng arrhythmia in this lesson because this is not amenable sa long-term pharmacologic therapy. Kumbaga, kapag ang type ng arrhythmia, meron ang patient is bradyarrhythmia, okay, bradycardia type na arrhythmia, dili effective ang long-term gamot. Okay? Dili effective ang long-term ang nagamot. Okay? So, dili effective ang drug therapy nga pang long-term. Okay? Instead, ang ginagamit sa bradyarrhythmia, ang ginagamit is non-pharmacologic approach. Okay? So, pinaka-effective sa ilaha ang non-pharmacologic interventions. Example, pag may bradyarrhythmia yung patient, naglalagay ng mga devices lang sa heart niya para mag-induce ng action potential. Okay, so non-pharmacologic yan. Kasi devices, walang involved na gamot. Okay? So usually, ang mga applications ng mga anti-arrhythmic drugs or agents nakafocus sa counteracting tachycardia. Okay, counteracting tachycardia. Again, dito applicable ang mga pharmacologic treatments or mga drugs. Okay? So, tanan nato ma-discuss agents under this lesson. They have clinical benefit in the management of tachyarrhythmias, okay, or tachycardia. Now, ang flow sa discussion, akong flow sa discussion sa preceding slides, preceding presentations, mag-start ta diri sa disorders of impulse formation. So, dira ta mag-start. Okay? Discuss nato yung kind of arrhythmia wherein ang cause or ang pathophysiology, okay, problem behind is nagkakaroon ng disorder sa impulse formation. Okay? Wherein as mentioned, kapag impulse formation ang pinag-usapan, ang involved ani is the pacemaker cell. Okay? Siya diba yung nagpo-form, nagge-generate ng impulse. Okay? Yung pacemaker cell or yung sino-atrial node. Okay? So mag-revolve atong discussion here sa SA node. And then it will be followed by disorders of conduction system. Okay? Disorders sa conduction systems wherein dito naman may kinalaman yung mga areas, yung mga parts outside the SA node. Particularly, AV node, Purkinje fibers. Okay? So, start ta sa disorders of impulse formation. Okay? Disorders of impulse formation. Again ha, pag impulse formation, this involves sino-atrial node. Okay, so dalawa ang possible problems, okay, in relation to the pacemaker cell, in relation to the SA node, causing arrhythmia. Number one, pwedeng no signal from the pacemaker site. No signal from the pacemaker site. Okay, so ito yung isang pwedeng problem sa pacemaker site. No signal, meaning walang action potential. Siyempre, kung walang action potential, pwedeng wala masyadong contraction or bale, bumabagal masyado ang contraction, resulting in bradyarrhythmias. Okay? So, pwede siyang intermittent. Again ha, hindi effective ang drugs dito long term. Okay? Basta bradyarrhythmias, hindi effective yung drugs dito long term. Long term. Another problem could be development of an ectopic pacemaker. Okay, development of an ectopic pacemaker. Ectopic, meaning sa ectopic, outside. Again, ibig sabihin ng ectopic, outside, labas. Okay? Again, sa second problem mechanism sa impulse formation, pwedeng magkaroon ng ectopic pacemaker, meaning pwede na ang initiator ng action potential, ang generator ng action potential, hindi lang si SA node. Okay? Hindi lang si SA node. So, pwede na ang action potential mag-originate hindi lang sa SA node. Okay? Kaya nga ectopic, di ba? Ectopic pacemaker. External one. Nagpapaka pacemaker. Ano ba yung mga possible ectopic pacemakers? Under this could be the latent pacemaker. Okay? Latent pacemakers. Okay? So sa part 1, ulit, na lecture video, may na-mention akong latent pacemaker cell. Diba? Example dito is yung si AV node. Diba? Sabi ko si AV node, atrioventricular node, isa siyang latent pacemaker. Again, pwede siyang maging latent pacemaker, ectopic pacemaker. Also, pwede rin si Purkinje fibers or Purkinje systems. I repeat, ang mga latent pacemakers, okay? Ang mga latent pacemakers are atrioventricular node and Purkinje fibers. Now, what do we mean by latent? Okay, latent, the term latent means dormant. Di ba? Dormant, nananahimik. Nananahimik siya. Ibig sabihin, at normal condition ng heart, normal, the one that dominates as pacemaker, syempre, the one that initiates action potential, and that is the sinoatrial node, normally. Again, sa normal condition ng heart, the one that initiates action potential normally is the sinoatrial node. However, there are cases na na-activate, na ma-manifest ang mga latent pacemaker. Okay, bali in certain abnormalities sa SA node, okay, or sa buong heart, ang atrioventricular node at saka ang Purkinje fibers, nagbibida sila. Okay, they create their own beats without waiting signals from the head pacemaker, from the sinoatrial node. Okay? So ano ngayon yung komplikasyon kung may sarili silang contraction. May sariling contraction si SA node. Okay? Ano yung magiging komplikasyon kung may sariling contraction yung SA node? Plus, nagiging independent then, or may sariling contraction din yung atrioventricular node tsaka yung Purkinje fibers. Ano yung pwedeng maging resulta? Magkakaroon ngayon, therefore, ng extra beating, di ba? Na yung mga extra beat karon ang heart. Magkakaroon ng extra beating on the heart. Kaya, end result, tachyarrhythmias. Di ba? Tachyarrhythmias. So, dito, iikot yung tachyarrhythmias na result. Arrhythmias. Okay? And this is obviously abnormal. Abnormal yan. Kasi dapat, di ba, ang utos manggagaling lang dapat kay sinoatrial node, kay SA node lang dapat manggaling yung utos. Susunod lang dapat si AV node tsaka si Purkinje fibers. But yun na nga, kapag may nagiging ectopic man sila, ectopic pacemaker, nagkakanya-kanya sila ngayon ng initiation. Okay? Initiation ng action potential. Kaya nga may extra beating, tachyarrhythmias yung resulta. Okay, kaya as stated here, sabi dito, may arise from emergence of latent pacemaker. So yung development ng ectopic pacemaker, it may arise from emergence of latent pacemakers like the ones I enumerated, yung atrioventricular node, saka Purkinje fibers. Also, may mga pagkakataon rin, okay, wherein may abnormal acceleration. Okay, may abnormal acceleration of latent pacemaker rate. Okay, abnormal acceleration of latent pacemaker rate. Okay? Kumbaga, may abnormal acceleration ng atrioventricular node saka Purkinje fibers. And also, too slow firing at the sinoatrial node. Firing at the sinoatrial node. That means that yung sinoatrial node is being blocked. Okay? Ibig sabihin nito, too slow firing at the SA node. Kumbaga yung sinoatrial node being blocked siya karon. Okay? Kay too slow man ang firing karon sa SA node. So somehow block siya. Kaya sobrang slow yung firing sa kanya. Okay? Therefore, kapag mayroong sinoatrial nodal block, SA node block, that initiates further ectopic pacemaker. Diba? Block man siya karon, somehow block man siya, slow man ang firing ng totoong, yung original talaga nga pacemaker, ma-activate yun further yung mga ectopic pacemaker. Okay? So kung na-initiate ang ectopic latent pacemaker, extra beating. Yan, extra beating na naman yan. Okay, so yan generally ang nangyayari pag may development ng ectopic pacemaker. Okay, so isa yung disorder sa impulse formation. Also, another contributory factor here na related sa discussion is yung external automaticity. Okay, external automaticity. When we say external automaticity, nagmamanifest ngayon ng automaticity ang mga non-pacemaker cells. Okay? Non-pacemaker cells like the AV node tsaka yung Purkinje fibers. Diba dapat ang normal lang na naga-automaticity, dapat ang normal lang na naga-automaticity is the sinoatrial node. Okay, dapat normal. Pero pag sinabing external, okay, external automaticity, yung mga non-pacemaker, nag-o-automaticity din. Okay? So that really causes extra beating. Okay? That is why naka-state dito under automaticity, 'di ba? Ability daw of non-pacemakers. Okay? Ability of non-pacemakers to undergo spontaneous depolarization, causing extra beat. Okay? Causing extra beat. Tachycardia. Okay, that is actually a problem kasi nga dapat ang mag-automaticity lang ay ang sinoatrial node kasi siya ang pacemaker. Siya ang original initiator ng action potential. Okay? Now, meron tayong dalawang forms, major forms ng automaticity. Pwede siyang enhanced. Pwedeng enhanced automaticity, ibig sabihin in this case, may enhanced firing sa sinoatrial node. Again, pag enhanced gani nga automaticity, ibig sabihin may enhanced firing sa sinoatrial node. Siyempre, kapag may enhanced firing sa sinoatrial node, that creates the faster phase 4 depolarization. Okay, again, enhance ngayon yung, di ba, enhance yung firing sa SA node, that will further result to enhance rate of phase 4 depolarization. Enhanced rate of phase 4 depolarization. And with enhanced rate of phase 4 depolarization, ang tendency bibilis. Bibilis ngayon yung rate of contraction. Diba? Bibilis ngayon yung rate of contraction. Kasi nga, normally, ang phase 4 may depolarization yan. Sumpayin na lang siya. Phase 4 depolarization na siya. Normally, ang phase 4, di ba? Phase 4 sa SA node, sa pacemaker. Always na ako siya gi-emphasize na depolarized yung phase 4 sa non-pacemaker, sa pacemaker, sa SA node. Okay? Depolarized na. May contraction na somehow. Ngayon, kapag enhance pa ang rate ng phase 4 depolarization, lalong bibilis talaga ang rate of contraction. So that is enhanced. Okay, enhanced automaticity. Also, another form of abnormal automaticity is the triggered. Okay, triggered automaticity. When we say triggered automaticity, this means that second depolarization occurs prematurely. Okay, this is related actually to a refractory period. Okay, refractory period, naalala ba yung, di ba, refractory period, naalala sa part 1, sabi natin, yung normal nga action potential, dapat normal ang action potential provided that from phases 0, okay, until 3, matapos dapat siya. Di ba yan yung effective refractory period. Yan yung condition natin. Normal ang action potential provided na from phase 0 until phase 3, matapos dapat. Completed dapat ang phase 0 to phase 3. Then balik ulit to phase 4 resting membrane potential. Now, in triggered automaticity, even though hindi pa natapos, okay, hindi pa natapos yung phase 3 in particular, okay, another depolarization occurs or happens. Okay? So, yan yung triggered automaticity. Okay? Kung mingon taog another nga depolarization happens, we would expect good na may extra or biglaang upstroke. Okay? Biglaang upstroke. Okay? Sa graph. Okay? Wala pa gay nahuman si phase 3, bigla dayon ni upstroke. Okay, depolarization, di ba? Upstroke man ang depolarization. Okay, kasi nga second depolarization. May second depolarization sa triggered automaticity. Okay, so obviously, that is related to tachyarrhythmias. Okay, tachyarrhythmias ulit. Depolarization, contraction, tapos sige. Okay, sige siya, continuous siya, tachyarrhythmias yun na siya. Okay, now we have two classes of triggered automaticity. We have AYAD and DAD. Okay, yung AYAD, that is early after depolarization. Again, AYAD, that means early depolarization. After depolarization. Again, AYAD, early after depolarization. Then DAD is delayed after depolarization. Now, ano yung difference ng dalawa? Okay, based on description. So for AYAD, early after depolarization, it occurs, sabi dito, bali, ano yung nag-occur? Yung, yung second yung biglaang pag-upstroke, okay, saan nag-occur? Basta early after depolarization. So, yung biglaang upstroke daw sa early after depolarization nagaganap, nangyayari during late phase 2 or early, this is early early phase 3. Early phase 3. Again, during late phase 2 or early phase 3. Ibig sabihin, Okay, ibig sabihin ulit, ang biglaang upstroke or depolarization action potential makikita pagkatapos ng phase 2, okay, sa action potential at sa maagang, okay, or sa maagang phase 3 ng action potential. Di ba? Kaya nga, tingnan yung graph sa early after depolarization. Di ba kung naaalala nyo, ito yung phase 2, yung plateau. Di ba yan yung phase 2, plateau. Okay? Then may pababa, okay, may phase 3. Di ba? After phase 2, phase 3. Now, imbis na pababa yung graph, okay, pababa ang graph, biglang tumaas. Tama? Imbis na pababa siya, biglang tumaas ulit. Upstroke ulit. So that is early after depolarization kasi early phase 3 may upstroke ulit. Early phase 3 may upstroke ulit. Okay? Now, kapag naman delayed after depolarization, DAD, okay, nangyayari ang biglaang upstroke, biglaang depolarization sa early phase 4. Ibig sabihin late ng phase 3. Okay, later part ng phase 3. Okay? So again, when we say early phase 4, yes, natapos si phase 3, Okay? Then konting resting potential, okay, resting membrane potential, konti. Then biglang akyat ulit. Okay? Biglang akyat ulit yung graph. Okay? So ibig sabihin walang enough time para mag-rest ang cardiac cell. So hindi enough yung phase 4. Kaya siya delayed after depolarization. Later part ng phase 3, may depolarization na naman. Kanina sa AYAD, early part ng phase 3, may biglaang upstroke. Sa DAD, delayed sa later part ng phase 3, may biglaang upstroke. Konting pahinga, konting resting, membrane potential, upstroke ulit. Okay, now another figure that explained, okay, this concept of after depolarization is this one. Okay, ka na siya. On the figure above, if you can see, okay, if you can see on the repolarization phase, di ba? Repolarization phase, yan yung phase 3. Okay. By the way, ano ni siya ha? Non-pacemaker. Okay? Na nagpapaka-pacemaker. Example, Purkinje. Okay? Example, atrioventricular node, di ba? Yung Purkinje in particular, di ba non-pacemaker siya. Nagpapaka-pacemaker bigla. Okay? So, automaticity. Okay, now, on the figure above, we can see on the repolarization phase ulit, di ba? It has not yet completed. Hindi pa nga siya natatapos yung phase 3, nag-shoot up. Di ba? Nag-shoot up na naman yung graph. Okay, so ano ang tawag dito? Early after depolarization. Okay, so this is early after depolarization. Then in the figure below, natapos yung phase 3. Okay? Natapos yung phase 3. Oo, nakabalik nga siya sa resting membrane potential. Nakarating nga siya sa resting membrane potential, phase 4. Kaya lang, very short time ang resting state. Nag-shoot up na naman. Okay? So, kapag ang upstroke naganap sa early phase 4 or later part ng phase 3, delayed after depolarization. Okay? So, overall, that is the problem with automaticity. Okay? So, mabilisang recap. Ang automaticity tandaan nyo, basta yung automaticity, okay, normally, nangyayari talaga ito sa sino-atrial node. Okay? Siya talaga yung nag-automaticity. Kasi siya yung pacemaker. Okay? But because of certain problem that happen in that pacemaker, pwedeng ma-activate ang mga latent pacemaker. Ano yung mga latent pacemaker ulit? Latent pacemaker, ectopic pacemaker, we have atrioventricular node, tsaka Purkinje fibers. Ngayon, kung may mga alterations na mangyari sa sinoatrial node, pwede magkaroon ng enhanced automaticity or triggered automaticity. Kapag enhanced automaticity, ang salarin kay ang SA node. Okay, SA node. May problema sa SA node, enhanced yung rate ng phase 4 depolarization. Kapag naman non-pacemakers, okay, tandaan, kapag non-pacemakers yung involved, mga latent pacemakers, okay, kapag sila ang na-enhanced, okay, doon papasok ang triggered automaticity. Okay, dito papasok yung mga latent pacemakers. Okay, sa triggered automaticity. Okay, so under sila sa triggered automaticity. Wherein, the triggered automaticity, we have early after depolarization, then we also have delayed after depolarization. So we are done with disorders sa impulse formation, disorder sa impulse formation, which is one of the underlying pathology in arrhythmia. Okay, may problema sa pacemakers, okay, or sa related pacemaker cells. Okay. Now, moving forward, okay, sa arrhythmia, pwede din na may problema or disorder sa impulse conduction. Okay? Ibig sabihin, kahit normal yung sinoatrial node, ang problema ngayon is kapag pinasa na ng SA node ang action potential sa AV node, tapos pinasa ni AV node ang action potential sa bundle of his, then sa Purkinje, okay, fibers. Okay? Again, yung nagiging problema ngayon, oo, normal sa sinoatrial node, pero yung pagpasa ngayon, okay? Kapag pinasa na ang action potential to AV node, then to bundle of his, to Purkinje fibers, and so forth, okay? Nagkakaproblema kumbaga sa pag-transmit ng impulse conduction or action potential. Okay? Hindi sa pag-generate or pag-form ng impulse yung problema. Okay? Now, pag may problema sa impulse conduction, pwedeng ang result ay AV block. AV block or atrioventricular block. Atrioventricular node block. Ibig sabihin ng AV block, okay, the process of transmission mula SA node, okay, hanggang AV, hindi na facilitate, hindi tumawid. Okay, hindi tumawid yung transmission. AV block. Yan yung AV block. Ngayon, kung di tumawid mula SA to AV, we suppose na ang transmission, okay, kung hindi tumawid dito sa AV node, of course, we will really expect na ang transmission sa ibang parts, wala rin. Okay, wala rin. That's why atrioventricular block, that causes bradycardia. Barado ang conduction mula sa SA to atrioventricular node. Yan yung ibig sabihin ng AV block. Or kumbaga, yung nagiging result dito, sobrang prolonged. Okay? Sobrang prolonged ngayon ang transmission mula SA node to atrioventricular node. Okay? So, kung sobrang prolonged, sobrang tagal, babagal talaga yung conduction, babagal yung beating, yung rate ng heartbeat. And that is bradycardia. Okay? And then, pwede din namang magresulta sa tachycardia. Okay? So, again, pag may disorder sa impulse conduction, that could result to tachycardia. And ang process that could lead to tachycardia is known as a re-entry. Okay? Re-entry. Re-entry na siya. Re-entry. Re. Okay, re, R-E, then entry. Re, di ba, pag sinabing re, nga prefix, it means again. Okay, again. So, bali, papasok ulit. Entry, papasok. So, papasok ulit. So, may kinalaman ito sa retrograde. Dito ko na lang isulat. May kinalaman ito sa retrograde impulse conduction. Okay? So, may kinalaman ito sa retrograde, ang re-entry that causes tachycardia. Okay, that is related to retrograde impulse conduction. Okay, retrograde impulse conduction. Okay, sige, illustrate na ako. Okay. So, ayan. Ito na lang yung nasa right side na flow na ginawa ko mula SA node, AV bundle, then Purkinje. Diba yan yung normal flow? Again, itong highlight na blue ha, highlighter nga color blue na ginamit ko, yung flow na to sa right side. Please refer on that flow. Diba ang normal nga flow sa impulse conduction, normal flow sa impulse conduction is mula sa SA node, okay, to AV node, then to bundle of his, then to Purkinje and so forth. Yan yung impulse, normal impulse conduction, flow ng normal impulse conduction or flow ng action potential normal. Okay, so dapat diretso-diretso. Okay, diretso-diretso yan hanggang sa makarating sa Purkinje fibers, then finally, okay, mag-result to contraction ng ventricles. Okay, kasi yung Purkinje fibers, diba, makikita sa lateral part ng ventricles. So, kapag naipasa na sa Purkinje, there could be contraction of ventricles. Okay? So, dapat forward. Ito yung forward flow. Or yung tawag dito is anterograde. Sumpay na siya, ha? Anterograde impulse conduction. Ito yung normal. Okay, normal flow ng action potential, normal flow ng impulse conduction. That is anterograde impulse conduction, forward. Antero means forward. Again, antero means forward. Now, kapag retro ang nangyayari, retrograde impulse conduction, somewhere along the way, may bara. Okay? May bara along the flow, merong defective tissue, kumbaga, may part ng puso na barado, may problema. Kaya yung transmission ngayon ng impulse ay hindi magpo-proceed. Hindi siya mag-proceed. Instead, mag-U-turn siya. Okay? Mu-U-turn siya. Mu-U-turn. Okay? Mag-U-turn. So, dili siya mag-proceed, mag-U-turn siya. Okay? Di ba pag sinabing pabalik, retro. Okay? Nag-U-turn siya, pabalik, so retro. So, yan yung retrograde impulse conduction. Hindi nag-proceed yung impulse conduction, nag-U-turn, bumalik. Okay? Now, in retrograde impulse conduction, once bumalik, yung action potential, kung asa siya gikan, kung asa siya nag-originate, extra beat na naman yon for that tissue kung asa nag-originate ang impulse. Diba? So, magko-contract na naman. Okay? Probably, makurat-kuratan yun ang tissue kay na ay unwanted beating sa area nga dili na dapat. Okay? Kay wala na dapat siya beating. Kay napasa naman niya ang action potential. Then biglang bumalik, may retrograde impulse. So extra beating talaga yung mangyayari sa kanya. Okay? So tachycardia yung effect, di ba? So may re-entry, kumbaga pabalik ulit. Okay? So, yung normal, makikita natin, di ba, ang transmission ng, tingnan sa illustration. Okay? Ang normal, okay, kung imuhang tan-awon sa illustration, ang transmission ng action potential, walang pagbabara. Okay? Sa illustration, letter A, walang pagbabara. Okay? So, anterograde. Anterograde. Okay? Antero, move forward. So, forward lang siya, forward. Now, pag nag-transmit ng action potential, usually, listen, kapag normal normal na transmission ng action potential, usually may part na siya always, may part always ng action potential na magko-collide. Okay? Magko-collide with one another. Okay? And collision of action potential in a certain part, in that certain part, okay, that causes cancellation. Cancellation of electrical charges. Okay, syempre kapag nag-cancel out, wala nang beating yun. Diba? Nag-cancel out man, walang beating. Okay? Ayan. Kaning mga one-way, okay, one-way, okay, yan yung may mga beating. Okay, yan yung may mga beating. Kapag one-way, unidirection lang. Unidirection. Yan yung may beating. Okay, pero pag bidirectional, dalawa nag-collide, okay, na-cancel out. Yung electrical charges, no beating yan. Okay, so that is normal. Okay, so that is normal. Now, kapag hindi na normal ang flow, please refer sa letter B na illustration. Kung hindi na normal ang flow, example, may blockade. Okay, may blockade sa portion na yan. Okay, for instance, ang tao nagkaroon ng infarction, myocardial infarction, which is one of the causes of arrhythmia. Diba? So, defective ngayon yung tissue na to. Okay? So, defective na siya. Ang tissue na yan sa puso ng patient. Okay? That's why kung barado yan, hindi makapag-proceed ang action potential. Diba? Hindi makapag-proceed yung action potential in that way. Kaya ang tendency, hahanap siya. Tingnan yung flow. Diba? Pag block, tingnan mo yung flow, hahanap siya ng ibang way para ma-release. Diba? Hahanap siya ng ibang way para ma-release ang action potential. That's why mo-bounce back siya. Kada bounce back, extra beating yun. Okay? Kaya magbibit dito na part, magbibit, okay? Magbibit na dapat tapos na. Diba? Tapos na. Then, may paparating ulit. Okay? May paparating ulit. Bounce back na po. Dadami ngayon yung extra beating. Okay? So, another thing, dahil may blockade sa part na yan, tingnan, di ba may blockade sa part na to. Okay? Hindi visible ngayon yung cancellation. Tingnan yung part na to. Kay may block dira nga part, dili na karon unidirection. Diba? Dili na karon dili na karon bidirectional. Okay? Dili na karon bidirectional. Unidirectional na ngayon. Okay? Wala siyang ka-opposite na direction, kumbaga. Diba? One direction, wala siyang ka-opposite, hindi bi-direction. Kasi nga, barado yung part na to. Kung bara, ni bounce back na siya, wala siya ni proceed sa iyahang dapat nga proper way. Okay? In transmission ng action potential. Now, ano yung implikasyon kapag hindi na cancel out yung part na to, dili parihaan eh. Okay, dili parihaan na nga part. Kung hindi na cancel out, okay, syempre, extra beating ulit. Okay, extra beating ulit. So, ang daming beating na di dapat mangyari basta may unidirectional unidirectional block. So, yan yung nangyayari sa re-entry. Re-entry. Okay? Sige, isa pang figure. Okay, kani siya ako ni siyang gi-extract na figure sa Katzung. So, pwede rin ninyo i-read out. Okay, yung details about this figure. So, ganun pa rin, sa normal conduction, diba, sa normal conduction, as you can see, na-extinguished. Okay? Na-extinguished meaning na-cancel out. Okay, na-extinguished ang action potential dito na side. Okay? Kasi nga, opposite charges sila. Diba? Opposite charges, so magka-cancel out sila. Okay? Kasi it facilitates normal anterograde in this portion. May bidirectional block. Okay? Bidirectional. Pero kapag may depressed region, okay, pag may depressed region, like for example, may injury sa myocardium. So instead of anterograde, retrograde yung nangyayari. Okay? So, ang nangyayari, may nababalik. Tingnan. May nababalik, diba, na action potential. Kaya pansin nyo, walang naka-cancel out, diba? Sa iyahang figure, walang naka-cancel out na charges. Walang elimination ng charges. Kaya nagkakaroon ng extra beating. Kasi nga, unidirectional lang. Okay? Kasi pag walang cancellation, walang collide, one way lang, beat yun. Okay, beat. So, ang daming extra beating na nangyayari pag unidirectional block. Okay? Now, another figure, during impulse conduction na normal, ayan, kung normal nga impulse conduction, example, by the way, impulse conduction atong ginasturyahan dira ha. Impulse conduction, pwedeng impulse conduction ng atrioventricular node, ng bundle of His, or ng Purkinje. Okay? Yung related sa disorder of impulse conduction. Okay? So again, sa normal, yung figure above, na-extinguish ulit. Ba, na-extinguished, na-cancel out, na-eliminate ang action potential because of normal passage of impulse. Okay? Kaya normal, kung titingnan mo yung action potential illustrated, example, action potential to ng AV node or Purkinje or bundle. Okay? Normal yung action potential being illustrated. Okay? And kapag naman may blockade dito, diba, pag may blockade, ayan, may blockade, imbis na bidirectional, nagiging diba, unidirectional. Okay? So, kapag unidirectional, hindi ma-facilitate yung cancellation of charges. Kaya ang tendency, may abnormal contraction. Okay? Hindi pa tapos, okay? Hindi pa nga tapos yung phase 3, biglang nag-upstroke na naman. Ang daming beating, ang daming extra beating if you'll interpret the graph. Diba? So, tachyarrhythmias. Okay? So, yan yung concept ng re-entry, anterograde, ayan, impulse conduction. So, i-summarize natin para mas ma-reinforce ang concept. Sabi kanina sa mechanisms of cardiac arrhythmias, may dalawang main causes or pwedeng tatlo. Diba? Pwedeng ang problema is sa tagagawa ng action potential. Okay, meaning ang problema is ang pacemaker or sinoatrial node. Or kaya naman problematic is yung pagpasa ng action potential. Or pwedeng tatlo yung problem, combination. Okay? Now, unsa atong na-discuss about sinoatrial node. Diba? Isa sa mga very emphasized kanina is yung automaticity. diba? Under disorder sa impulse formation. Wherein sa automaticity, more on tachycardia, diba? More on tachyarrhythmias. So sa automaticity, pwedeng na-enhanced, okay, ang phase 4 ng sinoatrial node or pwedeng na-block siya. Ngayon, kapag na-block ang sinoatrial node, remember, may mga latent ectopic pacemaker ngayon na activated. Ano yung mga latent pacemaker na yon? We have, okay, AV node and Purkinje fiber. So most probably mag-e-extra beating. Mag-e-extra beating sila. Bakit? Kasi ang problema, pwedeng may external automaticity. Okay? May external automaticity. Okay? May automaticity outside the SA node. So ito sila nag-automaticity. Okay? So pwedeng enhanced or pwedeng triggered. Okay? Another, pwedeng ang problema sa arrhythmia, okay, is yung sa conduction. Again, pwedeng ang problema sa arrhythmia is sa conduction of impulses, wherein yung proseso ng pagpasa, instead of anterograde, which is the normal, it becomes retrograde. Okay, so nagkakaroon ng blockade. Okay, blockade. Dahil sa blockade na yon, hindi na extinguished ang impulse. Hindi na eliminate because of blockade. Okay? And dahil hindi cancelled out ang charges, extra beat yun. Okay? Tachycardia related. Okay? So, yun yung mga posibleng, okay, major mechanisms or underlying pathology with the condition cardiac arrhythmia. Now, moving on, let us now proceed to the different types of arrhythmia. Okay? Different types of arrhythmia. Basta ang point lang yun, ang point sa arrhythmia, may problema sa electrical conduction system ng heart. Now, for the types of arrhythmia, first, kapag ang problema is sa sinus node, ibig sabihin sa sinoatrial node, pwedeng magkaroon ng sinus tachycardia or sinus bradycardia. Ibig sabihin pala, no, kapag narinig nyo yung terms na tachycardia, bradycardia, hindi siya in general buong puso. Okay, it depends on the part kung ano yung affected, causing tachycardia, causing bradycardia. So again, una, we have sinus tachycardia, sinus bradycardia. And then, another type, we have atrial arrhythmia. So we have example, atrial fibrillation and atrial flutter. Okay? Atrial flutter yan. Wala na ako nasulat, no? Atrial flutter. Just take note of the number of beats para ma-differentiate nyo. And then we also have nodal and other supraventricular arrhythmias. Okay? Again, also a type of arrhythmia. We have nodal and other supraventricular arrhythmia. Example, atrioventricular block. Okay? Atrioventricular block. Now, ang atrioventricular block, diba, that is characterized by prolonged PR interval. Naalala ang PR interval sa lecture 1? Okay, sa part 1 ng arrhythmia. Diba, I have emphasized na ang PR interval ng ECG, ito yung travel time mula SA node to AV node. So, kapag AV block, okay, AV block, yung pasa daw, excuse me, prolonged. Yung pasa dito is prolonged, sobrang tagal. Okay? So, balikan nyo lang yung foundation natin about cell electrophysiology. Na-discuss ko naman to. Then, we also have, ayan, supraventricular tachycardia. Ayan, supraventricular tachycardia. So, we have intranodal and extranodal supraventricular tachycardia. Okay, sa intranodal, ito yung re-entry. Okay, ito yung re-entry which is na-discuss kanina. Di ba yung concept? Kaya nagkakaroon ng extra beating sa supraventricular part of the heart. So, kasali dyan yung atrioventricular node. Then, extranodal SVT, supraventricular tachycardia. Usually, secondary effect sila. Secondary effect siya, okay, caused by diseases like Wolff, Parkinson's White, and Lone-Ganong-Levine syndrome. Okay, kumbaga yung arrhythmia dito, extranodal SVT type of arrhythmia is a secondary cause by a particular disease. And then finally, ventricular arrhythmias. Obviously, dito affected yung ventricles. Okay, ventricles. So, number one, we have ventricular ectopic beats wherein may abnormal QRS complex. Recall, QRS complex. Ano yung ibig sabihin ng QRS? Interpretation natin sa QRS complex sa ECG. Di ba yan yung ventricular depolarization. So, ventricular depolarization or equivalent to ventricular contraction. So, nagkakaroon ng abnormal ventricular contraction, ventricular arrhythmias. Okay, yung resulta. Next, ventricular tachycardia. Ibig sabihin, mabilis. Okay, mabilis, malakas ang contraction ng ventricles. Okay, kaya maraming QRS complex. So, kumbaga, kung maraming QRS tayo makikita sa ECG, somehow yung ani iyahang inyong makita sa something ana. Okay? Yung appearance niya. Okay, maraming QRS. Di ba nga na ang iyahang? Somewhat ingani ang QRS. Okay. So, ingana. And then, ventricular fibrillation. Yung ventricular fibrillation, this is fatal. Fatal na form or type ng arrhythmia sa mga patient. Okay? So, yun yung mga types ng arrhythmia generally. Okay? By the way, good to know lang yung mga types of arrhythmia, ha? Mas inaaral kasi yung mga types of arrhythmia deeply pag nag-med school na mo. Okay? Pag nag-med school na mo. Okay? Now, at this juncture, I will now give an overview of the drugs. So, overview na ta sa drugs. Since we are able to understand somehow yung normal rhythmic activity of the heart and then the possible problems that could occur, this time, ready na ta. Okay? Mahibalaan kung unsa dapat goals, okay? Unsa dapat objectives, okay? Ma-attain ang mga drugs, okay? Ang dapat ma-attain ng mga drugs to address the problem in arrhythmia. So for the general objectives, number one is to restore the cardiac arrhythmia. So restore the cardiac rhythm. Okay, restore the cardiac rhythm to normal. Okay, syempre general, yan yung isa sa mga general objective. Okay, so it will be discussed sa part 3 ng lecture video. Next, prevent arrhythmia recurrence by using drug for maintenance purpose or for long-term purpose. Okay, and then ameliorate the hemodynamic consequences of the arrhythmia. Bakit may hemodynamic consequences sa arrhythmia? Ang problema kasi sa arrhythmia, because of abnormal, di ba, may irregular rhythm, abnormal yung rhythmic activity. Okay, so nagkakaroon ng variable cardiac output ngayon. Diba? Dahil sa abnormal rhythm activity ng heart. So pabago-bago yung cardiac output, okay, volume ng blood that is being pumped out, ejected sa body. Biglang bababa, biglang taas, biglang bababa. Okay? Yung cardiac output. And recall, kapag baba yung cardiac output, may effect yan sa mga peripheral tissues. Kaya, we really need to address arrhythmia because it will eventually affect the tissues because of less cardiac output. And then, of course, reduce the risk of severe arrhythmia like ventricular fibrillation kasi very fatal to. Very fatal siya nga type of anemia. So to be able to achieve those general objectives, we have to use drugs that would specifically address the following goals. So number one is to suppress. Okay, we have to suppress automaticity. Okay, by the way, kanang akong mga i-discuss nga drugs, okay, yung mga i-discuss ko na drugs, ang i-address is yung tachyarrhythmias. Okay, tachyarrhythmias lang, hindi bradycardia. Kasi again, I repeat, hindi effective ang gamot long term sa bradycardia. Ayan. So again, number one, we have to suppress automaticity. Okay, suppressing the automaticity would normalize the problem. So this is mainly decreasing the frequency of discharge, which is an effect that is more pronounced in cells with ectopic pacemaker activity. So diba, remember, yung mga cells na may ectopic pacemaker activity are the ones that were initially latent. Okay? Na due to problem in sinoatrial node, they becomes hyperactive, causing extra beating, causing tachycardia. So para ma-address natin yung problema via suppressing automaticity, we can use agents that would decrease, okay? For example, the slope of phase 4 depolarization. Ibig sabihin, papakalmahin yung sinoatrial node. Okay? So ginasolusyonan nato diri particularly ang enhanced yung enhanced automaticity. Okay, ang ginasolusyonan diri. Kaya di ba kung inyong i-recall ang slide ganina, when we define enhanced automaticity, increase daw yung phase 4, rate of phase 4 depolarization. Okay, so with the use of drugs, meron tayong mga drugs that will address that particular enhanced automaticity. Gina-target. Okay? Ginatagaan og solution. Gina-decrease nato ang slope of phase 4 depolarization. Kasi, di ba, problema to. Problema ang enhanced automaticity or increased rate of phase 4 depolarization. So with the use of drugs, again, they will decrease the rate of phase 4 depolarization. Ngayon, if you still remember, sa phase 4 depolarization, sodium ions comes into play. Again, sa phase 4 nga depolarization, phase 4 depolarization, naay part, okay, naay contribution dito ang sodium ions. Okay, particularly the sodium ion channels wherein nagkakaroon ng entry of sodium ions inside the cell causing depolarization. Diba? So, para pakalmahin ang enhanced automaticity na nangyayari, there are drugs that could block, okay, sodium ion channel. And syempre, ang tawag sa kanila, sodium channel blockers. Okay, sodium channel blockers. And then, we can also use drugs by, wherein meron silang mechanisms, general mechanism to raise the threshold of discharge to a less negative voltage. Ang ibig sabihin lang nito is to keep the cardiac cell at rest, or not really at rest, but less active. Okay, less active. So counteracting tachycardia rin, suppressing automaticity rin. Okay? And also, another goal ng antiarrhythmic drugs is to prevent re-entry. Kasi another problem, yung re-entry. Di ba sa re-entry, akong gi-emphasize ito, nagkakaroon ng retrograde impulse causing di ba, unidirectional impulse. Okay? So, walang cancellation of charges ang kakahitabo sa re-entry. Kaya nagkakaroon ng extra beating, tachycardia effect kapag may re-entry. Kaya bounce back man ang action potential. Imbis gipasa na gani ang action potential, biglang nibalik, beat na pod extra beating. Now, we can prevent re-entry by converting a unidirectional block into bidirectional block. Kasi ito yung normal, yung bidirectional block. Okay, so with the use of drugs, bidirectional block needs to be established wherein walang retrograde na mangyayari. 'Di ba? Maka-cancel out na ngayon yung electrical charges, walang extra beating. Okay, therefore, enhancing refractory period. Prolonging, gina-prolong na to ang conduction time. Okay, ng action potential. Kaya tatagal ang oras para matapos ang isang action potential. Okay? So, naging enough time para effective yung refractory period. Okay? Kaya nakalagay dito, di ba, slow conduction, slower beating. Siyempre, kung slow yung rate of beat, that is bradycardia effect. So, counteracting counteracting the tachycardia, okay, effect caused by re-entry. Okay, kaya iya man ginapa-slow ang conduction, slow ngayon yung rate of beating. Okay. Now, to be able to suppress automaticity and then prevent re-entry, we can use these drugs with the following mechanisms of action. So, ito yung magiging major mechanisms ng anti-arrhythmic drugs. So, number 1, drugs that block sodium ion channel. Okay, so somehow naana mo yung idea, 'di ba? Unsa pwede mag-result kapag gi-block ang sodium channel. Diba? Example, this is the cell membrane. Sodium ions are normally positive lang yan. Okay, sodium ions are normally found outside the cell membrane. So, block ngayon, okay, yung daanan ng sodium ion channel, kung block, so alam niyo na kung ano yung magiging effect or result pag na-block yung sodium ion channel. Okay, so in general, kapag na-block yung sodium ion channel, of course, we would expect na nabablock ang pagpasok ngayon ng sodium ions inside the cell. So atong realizations dapat is gina-target niya ang depolarization. Diba? Pigil ang depolarization ngayon somehow with a blockade effect or blocking sodium ion channel. Next, there are also drugs that blocks sympathetic autonomic effects in the heart. So, nganong importante man na i-block ang sympathetic effects? Recall that sympathetic autonomic nervous system, it has contributory effects sa heart rate. Ibig sabihin sa chronotropy, napod siya contributory effects sa conduction velocity, sa dromotropy. Wherein, generally, basta sympathetic effect is activated, it causes tachycardia. Diba? So, napapaikli niya yung PR interval. So, na-discuss ko to sa first video. With sympathetic effect, sympathetic response, pinapaikli niya, shorter ngayon yung PR interval, causing positive dromotropy. Okay? Kung positive dromotropy, sobrang bilis ngayon ng conduction velocity. Okay? So, tachycardia. And also yung depolarization due to firing, sobrang enhanced. So, with these effects, blockade of sympathetic autonomic effects, okay, ma-address na to ang tachycardia nga problem caused by sympathetic influence or factor. Also, prolongation of the effective refractory period. This can be achieved by, take note, blocking. This can be achieved by blocking potassium ion channel. That can be achieved by blocking potassium ion channel. And then finally, calcium channel blockade. Okay, so with that, okay, with this flow, we can classify anti-arrhythmic agents into 4. Diba? into 4 classes. So, ang tawag natin sa mga sodium channel blockers, sila yung class 1. Okay, class 1 antiarrhythmics. Again, class 1 antiarrhythmics, sodium channel blockers. And then these agents that block sympathetic autonomic receptors, particularly beta kasi sympathetic effects of the heart daw. So beta receptor particularly. Okay? So for these agents that block beta receptors of the heart, sila naman yung class 2. Or these are also known as beta blockers, di ba? Beta blockers. And then class 3 are, di ba, blocking potassium ion channel. So these are potassium channel blockers. So siya naman yung class 3. Again, class 3 antiarrhythmics, potassium channel blockers. And then finally, class 4 are the calcium channel blockers. So kabisaduhin nyo to ha, para every time I mentioned class 1, alam nyo na nga sodium channel blocker. Basta mayroon kong class 3 antiarrhythmics, kabalo na mo potassium channel blockers. Kung mayroon kong class 4, calcium channel blockers sila. Okay, and so on and so forth. So, yan yung classifications ng anti-arrhythmics. We have 4 all in all. Now, for the therapeutic overview, na-discuss ko na to, di ba? Ang therapeutic overview. So, we have the first 4 classes ng anti-arrhythmic. So, that will be the flow of the drugs that we will be discussing. We also have miscellaneous. Okay, these are the miscellaneous anti-arrhythmics. Okay, anti-arrhythmic agents, miscellaneous, adenosine and digitalis glycosides.